Welcome everybody to this webinar, and it's a pleasure to be here with you through this internet connection. I hope you can all see me, and we will do some teaching about imaging in AD, as you saw in the title. I've broadened the scope of the lecture a little bit, so I will not only talk about AD, but also about some other dementing disorders, so that you get a feeling for how specific the imaging findings are in Alzheimer's disease. You know what a radiologist's take is on what you can see on images when patients come with a suspicion of dementia and are worked up with imaging. And I will talk about the structural imaging in the first part, so mostly MRI, and then switch gears and talk more about molecular and functional imaging in the second part of my talk. So I've prepared a lecture for about an hour and a half, which is long, I realize. So if you're tired, just let me know and we'll stop and we'll continue some other time. I'm a neuroradiologist by training, so I trained mostly in use of CT and MR, and progressively went into functional and then molecular imaging. And I made the recommendations for the imaging protocol that we use in EPAD, which has a core structural MR part and advanced imaging. And then we realized that there was also a need to do molecular imaging, especially amyloid imaging, given the nature of the study. And then when a second project was launched, I became the project leader of Amyloid PET, but I see that as a natural extension from EPAD into Amyloid PET. So in my head, there are very interlinked projects which serve the same goal, despite the fact that Amyloid PET, in addition to EPAD, also has a diagnostic study embedded, whereas EPAD is only a prognostic protocol. All right, let's get started. So as I said, I broadened the title a little bit from simply talking about Alzheimer's disease to talk about neuroimaging and dementia at large. Let's see if I can move it. These are my disclosures. So I do a bit of consultancy for various companies, some in the MS field, some in the dementia field, including I do quite a bit of safety readings for Alzheimer trials, mostly for Roche and Janssen studies, where I work with Ixico and others to look at the occurrence of ARIA, which is a side effect of immunotherapy. And I'm also in the IDMC of a trial from Roche and in the steering committee of the aducanumab trials for Biogen. And I have some sponsoring, which includes, of course, the Amyloid PET and EPAD staff, and in some editorial boards. And here's an outline of what I would like to discuss. So the first part is will occupy almost half of the lecture, going through the things on structural imaging that we can recognize in dementia. So talk about Alzheimer's, FTD, other disorders, how you can recognize them by their pattern of atrophy. But we'll also talk about vascular pathology, which is a different sort of pathology. We have neurodegenerative and vascular pathology, which can both interact on the patient's well-being and sometimes even accelerate one another. And I'll talk about specificity and sensitivity of various measures, especially for the earlier stages. And as you will note, and probably already know is that MR is reasonably good at later stages. In dementia stage, in pre-dementia stage, becomes increasingly difficult. Hence, we need other tools such as molecular imaging and functional imaging techniques to depict earlier changes, which is relevant for EPAD, where you want to do secondary prevention, so basically intercept subjects before they become demented. And then lastly, I will talk a little bit about disease models and the secondary prevention and therapeutic monitoring. Okay, I think I can skip this slide. You probably know that the incidence of dementia is rising rapidly in many European countries, hence the need to do something about it before the disease sets out. I took these pictures from so at the bottom of the slide, all the time you see the references where I took images from. And I can strongly recommend this review paper, which was a year and a half ago, appeared in Lancet Neurology. Very exhaustive review about all aspects of the disease, including diagnosis, prognosis, risk factors, and I show various images from that review paper. So talking about structural imaging, I will show a lot of slides from my book called Neuroimaging in Dementia, which I did with Nick Fox, Antonio Bastos-Leit from Portugal, who was with me as a PhD student in Amsterdam, and with Nick Fox, my dear friend and contributor here in UCL. It's a relatively didactic book, giving a lot of schematics about how to systematically evaluate scans and come to a differential diagnosis. And I will show some highlights from things that are in the book. And a lot of this information is also on a website called the Radiology Assistant, which you might have heard about. I will show the link in one of the slides, and I'll stress that it gives a sort of condensed overview of the things that I'm presenting today, especially from the structural imaging part. So I will talk briefly about when and why to do imaging in dementia, and how to sort of systematically go through it, what sort of features should we evaluate, and then talk about atrophy patterns in various diseases, especially AD, but also FTD. And then briefly mention some other neurodegenerative diseases, dementia with Parkinsonism, such as PSP, for example, Creutzfeldt-Jakob disease briefly, and then talk quite a bit about vascular pathology, which is yet another type of pathology that can lead to dementia. And in fact, in a lot of large post-mortem studies, the best prediction of who was demented was actually a combination of vascular and neurodegenerative pathology. So when somebody is suspected of having a dementing disorder, this is the overall framework on how to operate. So if there's a suspicion and you come to the GP, first thing he will do is rule out a metabolic course, for example, diabetes or other things, or psychiatric disease like depression that may present like dementia, but in fact are not dementia. Once there's still a suspicion of dementia, then at some stage the recommendation is to do structural imaging at least once. It varies a bit from country to country, but most European countries have this recommendation. And the goal is actually a bit simplistic, is to rule out hydrocephalus or a tumor or a hemorrhage. But in fact, we can already show a lot of the features of a certain dementing disorders, for example, Alzheimer's dementia. So you can be more inclusive rather than exclusive. In principle, we try to do MR in everybody that we see in our memory clinic, but sometimes CT can be enough or is necessary, for example, if there's a contraindication for MR, or in very elderly patients where you're more excluding a tumor rather than finding subtle early changes of Alzheimer's disease. And if it's negative, you can consider either repeating the MR or CT examination after a year or two, or move on to a second line investigation, either SPECT or mostly PET these days. And we'll talk about that in the second part of the lecture, what you can see on those imaging modalities. In terms of the MR, we need to go through a structured approach, and I realize that the right side of the panel is too busy. But I will read out the orange blocks for you. So first of all, is there some structural lesion like a tumor or hydrocephalus or anything with mass effects or an AVM? If there's not, is there any brain swelling, as you can see in certain disorders, for example, patients with encephalitis or PML? If that's not the case, is there anything that has high signal on the flare? Can be either in the cortex, for example, in Creutzfeldt-Jakob, or can be in the white matter in patients with CADASIL or another form of vascular dementia. If that is not the case, or no relevant hyperintensities are noted, then we look at the atrophy pattern, which can either be focal or general. Even if it's focal, we need to know where it affects, for example, the mesocephalon in PSP, where it affects the temporal pole, for example, in FTD, or the hippocampus in Alzheimer's disease. If it's general, we have to make a distinction between normal aging or more generalized atrophy patterns, such as we can see in Lewy body dementia, but also in some Alzheimer patients. And as I said already, if it's negative, you can consider repeating the examination after, I would say, at least a year, if not 2 years, or moving on to the nuclear medicine examination. Here's the routine MR protocol for dementia. So routinely, we do not inject contrast materials and no gadolinium. The most important sequence is a 3D anatomic T1 weighted sequence, like an MP-RAGE or SPGR. So all the vendors have different names for this sequence, which provides an isotropic thin slice series of images which you can reorient in a different direction. We tend to make them in a sagittal direction and then reslice them coronally to look at the medial temporal lobe for atrophy of the hippocampus. And this should be a coronal one that is slightly tilted to be perpendicular to the long axis of the hippocampus, which is not in a straight transverse plane, but slightly tilted in the head. Then secondly, we do a FLAIR and a T2 turbospin echo to look at ischemic changes, infarcts, etc., as you can see on this side. And I will explain to you in a bit why we do not only do a FLAIR, but also a T2. Then we perform a gradient echo T2 star weighted image, or an SWI, which is a sort of high-end gradient echo image with 3D acquisition and some additional tricks to see microbleeds and calcification better. And then DWI, just a simple trace DWI, so nothing with tractography, nothing fancy, very simple sequence, which will allow you to see recent ischemia, but also Creutzfeldt-Jakob disease, which of course is a very rare disease, so most of these DWI examinations are negative. Then, as I said, structured reporting, exclude the tumor, look for swelling, look at the pattern of gray matter loss, look at vascular pathology, but also consider other diseases in the white matter. And I'll show you some examples of that in a minute. Here's an example of swelling in a patient with herpes encephalitis. These patients tend to have a sort of subacute, if not acute onset, so slightly different than the typical dementia patient with disorientation, memory loss, and can also develop epilepsy. Often affects the medial temporal lobe, including the hippocampus, but quite typically spreads to the other parts of the temporal lobe, often also involves the insula. Can be bilateral, but often unilateral. So the presentation is a bit more acute than you would see in a typical dementia case. Swelling otherwise, PML is another infection that may be associated with cognitive decline, mostly occurs in the setting of immunocompromise. So either a patient with chemotherapy or certain MS drugs develop PML and cognitive decline. Neoplastic disease, I'll show you an example of that. And then there's a group of what is called autoimmune limbic encephalitis. So these are antibodies against autoantigens in the brain. For example, against NMDA or against voltage-gated potassium channels. But there are an enormous amount of antibodies that can cause limbic or autoimmune encephalitis. And almost every week there's a new antibody discovered, and these are really difficult to recognize clinically, and also on imaging, because only 50% of them have imaging abnormalities, typically in the hippocampus and medial temporal lobe, but a lot of them have a normal scan. Here's a case of a gliomatosis. So this is a diffuse, low-grade, multifocal glioma, often has a tendency to affect the limbic structures. For example, here you can see that the cingulate cortex is affected, and the medial thalamus, which is also often involved in cognition, and often also in the hippocampus. And this was a patient that just walked into our memory clinic with a regular suspicion of dementia, and that was found to have this malignant tumor. Moving on to primary white matter diseases, which you may not think of immediately if you think of a dementia clinic, but we do come across them. So, for example, there are some infections that can cause white matter disease. For example, HIV infection can cause a diffuse white matter encephalitis type of picture. Inflammatory diseases like MS. I think at least once a year in our memory clinic we see a patient with MS who presents for the first time by virtue of the memory or cognitive problems, has never been diagnosed with MS so far. Similarly, leukodystrophies can present with cognitive decline. I'll show you some examples. An endless list of leukodystrophies, and we typically think of leukodystrophies as childhood or congenital disease. They are, of course, congenital, but manifesting early in life. But in fact, there are various leukodystrophies that present much later in life. And also here in London, where I work, there's a special leukodystrophy working group, and often the cases come from adult neurology, if not from the dementia clinic. And then there are toxic and metabolic diseases that may cause alteration in the brain that may present with cognitive decline. For example, delayed post-hypoxic demyelination is a condition that occurs in people who have been in intensive care, then come out of intensive care, and after 1 or 2 weeks develop a diffuse demyelination and cognitive slowing, which then sort of spontaneously resolves and take a long time. And then obviously we need to look at post-traumatic abnormalities, which are really common. And it's often quite a big debate whether, to what extent these traumatic abnormalities contribute to the clinical picture, especially if there are also, let's say, mild signs of Alzheimer's disease, and then you see additionally traumatic abnormalities. And probably the two pathologies add up, and they both impact on brain function. So if you have the theory is that people with a brain trauma have a lower threshold to develop Alzheimer's dementia because of a reduced brain capacity. Here's an example of a patient who presented to our memory clinic with extensive white matter diseases. You can see the bright signal on the flare here at the bottom row, but notice that inside these bright lesions there are areas that are apparently very destructive and have almost liquefied. Also on the T1, it's very dark. So this pathology is so severe. So unlike typical ischemic pathology, where you have bright signal and occasionally only a small lacune, you can see that most of the white matter is now rarefied. And this is a picture that immediately reminded me of the disease called vanishing white matter that we see mostly in children or young adults. And we tested this patient and was found to have the genetic mutation consistent with vanishing white matter. So this is just one example of the hundreds of diseases that can present with metabolic disorders late in life. And they're all rare, but since there are so many of these diseases, some of them may actually show up in your memory clinic. Another thing that can be bright is in the cortex is Creutzfeldt-Jakob disease. So CJD stands for Creutzfeldt-Jakob disease. And on the left hand you see a flare image. And if you look carefully, you can see that the cortex is not homogeneous. There are areas of the cortex that are a bit brighter than other areas, but it becomes much better recognizable on the diffusion weighted imaging. So this is a normal area of the cortex here. And you can see that there are multifocal areas in the brain that have high signal. In this case, it seems to be sort of more or less symmetrical, but in fact, it's usually asymmetrical and patchy with random pieces of cortex affected. And this is one of the reasons to do the DWI. And this picture is really pathognomonic of Creutzfeldt-Jakob disease. There is really no differential diagnosis. And mostly these patients are relatively rapidly deteriorating, so in a matter of months. But occasionally we do see patients who just report as regular memory clinic patients. We see this abnormality and they may be well, to the extent that the clinicians ask us, well, are you sure? Can it be something else because the patient is doing so well? Strange for a CJD. But then typically in 1 to 3 months afterwards, they progress as you would expect them to do. So Creutzfeldt-Jakob can have this typical neocortical pattern, but another group of Creutzfeldt-Jakob patients has involvement of the striatum, so involvement of the caudate and the putamen, can be unilateral or bilateral. So half of the patients roughly have this neocortical pattern, the other half have this sort of so-called striatal pattern. As I said, the biggest group of diseases is the primary gray matter disorders. And I will discuss mostly Alzheimer's disease, then a bit of FTD, which has a couple of subtypes, semantic, aphasic, frontal, and a right temporal variant. Then there are some dementing disorders that also present with Parkinsonian features. One of them being Lewy body dementia, the other being PSP, progressive supranuclear palsy, and then multisystem atrophy. And some of these you can recognize on imaging. Then there are other movement disorders with dementia, so non-Parkinsonian movement disorders that you can see in Huntington disease that often also presents early on with cognitive disturbances. And then we have neurodegeneration with brain iron accumulation, NBIA, the old Hallervorden spots and related disorders, and Wilson, which is another metabolic disorders. And then we already discussed the prion diseases, which we can recognize with our high signal on the DWI. Turning to Alzheimer's disease, here's a little cartoon depicting the sequence of events. So early on, there's an abnormality in the amyloid metabolism. So amyloid is a protein that occurs naturally in the brain. The function of it is largely unknown, perhaps anti-inflammatory. And for some reason, people on the path towards Alzheimer's disease tend to form aggregates of amyloid, dimers, oligomers, which may already interfere with nerve function and block synaptic function, and then form these larger extracellular amyloid plaques. And the common theory is that these plaques then secondarily induce intrafibrillary tau pathology, so-called neurofibrillary tangles. So the neurofibrillary tangles the tau plaques are inside the cells, the amyloid plaques are outside the cells. And in the middle, you see from the work of Braak and Braak staining for neurofibrillary tangles, which typically affects the medial temporal lobe. In fact, the earliest part effect is here in the parahippocampal gyrus, is called the so-called entorhinal cortex. So if you have pathology only in the entorhinal cortex, that's stage 1, Braak and Braak, and once it spreads into the hippocampus, you're already in there, stage 3. This is probably the moment that people present to a memory clinic with subjective complaints or even mild cognitive impairment. And then, because of the tau pathology, there's dying of neurons with subsequent neuronal loss and atrophy of the tissue with subsequent widening of the surrounding CSF spaces. On imaging, we can see these two ends of the spectrum. On the one hand, the volume loss that we can see on MR, but obviously this is a relatively late phenomenon, by which time you've lost a lot of neurons already in brain tissue. Whereas the early biochemical pathology we can see with amyloid PET, which is a very early phenomenon, and we'll discuss in a bit how early and how useful that can be. Turning back to the structural imaging of the hippocampus, it's important to look at the medial temporal lobe atrophy, and I'll use the abbreviation MTA for that. And there are various ways you can address this. One way is to try to calculate the volume of the hippocampus and its surrounding structures, which is quite labor intensive. I'll discuss the pros and cons in a bit. In clinical practice, we often use a visual rating scale. And here is from a study where we compared MR and CT performed on the same day. So at the top row, you see 4 MR images, and the bottom row 4 CT images, and these are the same subjects scanned with MR and CT. And you can see with a good quality CT scanner, so is able to make very thin slices in the transverse plane, and you can then reconstruct it in the coronal plane. And in fact, get image qualities that are not too bad if you compare it to the MR. The MR, of course, has better gray to white matter separation, but the CSF spaces you see really well. And this scale looks at the volume of the hippocampus and the surrounding CSF spaces, especially the temporal horn and the collateral sulcus. So in stage 0 of this scale, there's a normal size of the hippocampus, and you cannot see the choroid fissure, which is the space here, whereas in stage 1, this choroid fissure opens up a little bit, but otherwise the hippocampus and the medial temporal lobe still look fine. In stage 2, there's a bit more widening of the choroid fissure here, and more widening of the temporal horn now, which then progresses in stage 3 and stage 4. There's very little volume left of the hippocampus, and you see very clear opening also of the collateral sulcus here on the left side. And you can see that these later phases you can recognize fairly well on the CT. You tend to underestimate it a little bit on the CT, but in fact this opening of the choroid fissure you can see quite well already. The only difficulty is in stage 0 because of the low grade white matter contrast. It's really difficult to see where the hippocampus is, but if you don't see the inferior horn of the ventricular system or the choroid fissure, you can assume that the hippocampus is normal and give it a score of 0. So this score 0 to 4 I put in all my reports of patients who have a dementia scan, and most of the clinicians have a good feeling for what it means. The difficulty is that you have to define what is normal, what is abnormal, and that depends a little bit on age. So in patients under 75, so even in younger patients, you often see a score of 1. So seeing a bit of opening of the choroid fissure is not a pathological finding unless you're very young, let's say 30 or so. But in a 50 or 60-year-old, it's really not uncommon to see a bit of opening of the choroid fissure. So the first abnormality is if you have a 2 on one side. So on average, a score of 1.5. Whereas over 75, there's a bit more generalized brain involution, and then a score of 2 on both sides is required before you call a scan abnormal. Of course, this is a bit artificial, and it doesn't change overnight when you turn 75. So you have to take this with a grain of salt and take the overall picture into account when you interpret these values. If you want a bit more of explanation about the scale, as I mentioned, I put a lot of my material on a website called the Radiology Assistant, and you can see the URL below, www.radiologyassistant.nl. This is really a great resource also for other areas in neuroradiology. Or if you want to look at my MS work, you can find it there as well. But a lot of the slides and the information that I'm showing today is also on this website, including the rating scale for the visual rating scale for medial temporal lobe atrophy. Okay, what are the issues and the advantages and disadvantages? The advantage is that it's quick. You can do it on the fly while you're eyeballing the scan. The only thing that you need is a good quality T1 scan. Do not try to do it on a flare or a T2 weighted scan because you have a different contrast and you will make a different judgment. So it's important to always stick to the coronal T1 weighted images. There's a bit of training required, but not that much. I try to do what I can in various conferences on the website, etc. The disadvantage, major disadvantage, I guess, is the lack of subtlety, because there are only 4 steps in the scale, and you have to be, and to be honest, sometimes I'm doubting myself, and I just put in my report the MTA score is 2 to 3, for example, because there's not a step of 2.5. The alternative is to try to calculate a volume, the hippocampal volume. You can try to do it manually by outlining slice by slice and then adding it up, but that is really labor intensive. Easily takes an hour or so and needs a lot of practice. There are various software packages that will do this in an automated version. I've illustrated a few. Here is FreeServer. This is from FSL, but there are various others out there. They will calculate the volume, but it's good to realize that also these automated techniques are not perfect, and they agree sometimes, but sometimes they don't agree, and there can be huge differences between these volumes. And like with the visual scores, you have an interpretation problem, because with aging, if you look at the right side panel, you can see that with normal aging, the hippocampal volume goes down. And in AD it goes down as well. The only difference is that the whole curve has shifted downwards. So let's say a volume here for young AD patients is the same as the volume of an old control. So you have to take the age into account, the head size you have to take into account. So it's not that trivial. And depending on the exact protocol that you use in the exact segmentation software package that you use, you get slightly different values. So it's not that easy to use reference values from the literature, so you have to build up a local reference population to be able to interpret this well. So it's not that simple. So normative data are the biggest problem, I think. The other thing with a lot of these software packages is that they run on either in a cloud-based solution or on a workstation, which is not very practical. You know, the best thing would be if the scan got acquired on the MR, then it was processed on the scanner, and then the segmented images would be sent to the PACS, and then would be available for the whole hospital, which is often not the case. So, in actual fact, there's a lot of uncertainty about the value of doing volumetric analysis of the hippocampus. It's research studies, but to bring it to clinical practice, several hurdles still need to be taken. As I said, you can sometimes, if the scan is negative, think about repeating the scans. We don't do that very often. Here's an example of a patient who was in a research study who was an MCI at baseline. And here you can see not too much atrophy. There's a little bit opening of the choroid fissure, so an MTA score of 1, but not much more than that. If we now go to 2 years later, you can see that there's a clear change in the brain volume. You can see that the choroid fissure, I'm flipping between them a couple of times. You can see that the choroid fissure opens a bit more. But in fact, there's a lot of things that change. All the ventricles enlarge and the sulci enlarge. This is sort of thing, if you have the images done in the same plane, you can appreciate it with the naked eye. Although you need to have a couple of % change before you can really determine it with certainty. What can help, but again, this is a research tool, is to register images. So here's a study where we took images from 2 time points, have the computer register the images to each other. And if you then try to glue one onto the other, you have to deform one of the images, which is called a nonlinear registration or fluid registration. And it then shows in colors where you need to expand the tissue. For example, the ventricles need to be expanded to fit onto the follow-up image, whereas other areas need to shrink in green and in blue. And you can see that the shrinkage occurs in the temporal lobes mostly, but in fact throughout the brain, and the ventricular system enlarges. And if you then look at where the changes occur, so this is a plot showing on the vertical the regional atrophy rate in % per year, and on the horizontal we've plotted the various regions in the brain. If you focus on the top curve, which is healthy controls, so these were approximately 70-year-olds, you can see that there's on average a 0.5% tissue loss per year at that age. And it's roughly diffused throughout the brain. If you now look at the middle graph, which is the MCI group, you can see that they have on average more atrophy. So the whole curve is shifted downwards. So on average, they have probably a % volume loss per year. And notice that now the most atrophy occurs in the medial temporal lobe, but also already in the rest of the temporal lobe. But in fact, all other regions also show more atrophy. We now look at the lowest curve, which is Alzheimer's disease. You can see that, again, the whole curve is shifting downward, so the average will be about 1.5% per year, whole brain. And the most atrophy now occurs in the lateral temporal regions. So this is consistent with the pictures that I showed you earlier from the Brach and Brach stages. So the disease starts early in the entorhinal cortex, then goes to the hippocampus, then spreads to the lateral temporal areas, and then to the parietal areas and other parts of the brain. So it's a sort of spread from the medial to the undersurface and then to the lateral surfaces of the brain. Medial temporal lobe atrophy is, so we discussed in the setting of AD, but it's by no means specific for AD only. And it's, for example, a very prominent feature in frontotemporal dementia. Here's an example of patients with a semantic subtype of frontotemporal dementia who tend to have mostly temporal lobe involvement. You can notice that there's very severe atrophy of the hippocampus, an MTA score of 4, if not 5. So very severe atrophy. And in fact, if you see very severe atrophy, think first of FTD instead of AD. The other thing to notice, if you go a little bit back in the brain, you can see that there's a very strong asymmetry. So if you apply your visual rating scale and you give a score of 4 and you give a score of 1 or 2 on the other side, so if it's very asymmetric, it should be an automatic trigger to think of FTD rather than AD. So here's a table from our book showing the differential diagnosis of hippocampal atrophy. Obviously AD, where it tends to be bilateral. One disorder that also causes a lot of hippocampal atrophy is hippocampal sclerosis, which is really annoying because the clinical picture is the same as AD, the imaging findings are the same, but the pathology is completely different. This is a disorder that occurs mostly in very old people, so 80 plus, and I don't have a solution for that. In DLB, it tends to be a very late finding, and as I said, if it's unilateral, think of FTD. That is really important differential diagnosis. Here's an example of an FTD on the right side. So this is the mirror image of the semantic dementia that I just showed you, which is on the left side. Again, notice the very asymmetric involvement of the hippocampus, but also the remainder of the temporal lobe. And in this case, it also extends into the frontal lobe, as you would expect it, given the name of the disorder. And something that I forgot to point out, I'll go back for a second. So in FTD, semantic dementia, it's the hippocampus, but again, also the rest of the temporal lobe that's very severely involved. And overall, often the temporal pole is very atrophic, which is not something that you see very often in AD. So look at the temporal poles as well, look at asymmetry. Yeah, as I mentioned, so the frontal lobe involvement can also be very severe, especially if it's the behavioral variant of FTD. And here's a post-mortem case where it's obviously very severe. Notice that there's also a bit of involvement of the temporal lobe, but it's mostly the frontal lobe. But in normal clinical practice, we don't see this very severe atrophy pattern very often. So the temporal variants, the semantic dementias, when they come to the memory clinic, they often have a lot of atrophy already. The frontal cases tend to have much more subtle atrophy and cause many more problems in the routine clinical practice. So within FTD, there are various subforms. The behavioral variant that I just showed you, there are two language forms, the semantic dementia with the unilateral temporal lobe atrophy, and the non-fluent aphasia, which tend to have more inferior frontal gyrus atrophy around Broca's area. But within the FTD spectrum, we also have other tauopathies, notably cortical basal syndrome and PSP. And there are transitional forms between all of these disorders, some of which are tau positive, and there are various mutations, but some of them that are tau negative and have ubiquitin, and other mutations. And the difficult thing is that it's not simple to predict from the genetic mutation what type of disease will occur. So there's overlap between genes, proteins, and clinical expressions. And to go back to the genetic mutations, so genetic mutations can be found in some 10 to 20% of FTD cases, mostly if they're familiar. If they're non-familial cases, then it's perhaps lower. So in the vast majority of cases, there's not a definitive test that will prove that in the end this is FTD. As I mentioned, there are also various diseases that come with dementia and then Parkinsonism, including Parkinson's disease. Many patients with Parkinson's disease develop cognitive problems. And in fact, people think that DLB, dementia with Lewy bodies, and Parkinson's disease are in the end the same disease. Only some patients present first with the typical Parkinsonian features. Others present first with the cognitive problems, and some with a mixture thereof. And DLB is really a frustrating disorder for radiologists because the scans tend to be really quite normal early on in the disease. Later there may be generalized atrophy, but typically normal scans, including normal hippocampus. PSP, on the other hand, is very rewarding because we can see a very typical atrophy of the mesocephalon, and because the mesocephalon becomes very narrow and the border a bit concave, this is also called the hummingbird sign because it reminds people of a hummingbird. You know, this tropical bird with a long beak. And then in multisystem atrophy, we can have atrophy of the pons. So PSP is in the mesocephalon, MSA is in the pons, and you get loss of volume of the pons, and you can get this cross sign in the pons, which is typical of MSA. More rewarding for Lewy body dementia is to look at dopamine imaging, as you would expect in a Parkinsonian syndrome. So this was a PET study, but you can also use a DOT SPECT to show that there's abnormal uptake of the dopamine tracer in the striatum in DLB, whereas in AD you have a normal uptake, and also in FTD you have a normal uptake. Whereas with amyloid scan, which we will discuss in a minute, you can see that you see amyloid uptake in the AD, but typically not in DLB, and certainly not in FTD. So to make the point that a combination of these molecular traces can be of use, but especially for DLB, the preferred test is a dopamine scan. So far, when I talked about Alzheimer, I talked about the hippocampus a lot, and that is the typical mode of presentation in an older patient. So older Alzheimer patients tend to have hippocampal atrophy, but here's a very young Alzheimer patient, and there's a bit of hippocampal atrophy. You can see that the choroid fissure is open, but I would still give this an MTA score of 1 only, although we can see that there's also some atrophy occurring in the remainder of the temporal lobe. But what is more important is the atrophy that's occurring here in the precuneus and the parietal lobe. So the younger the patients are, the more they tend to have what is called posterior cortical atrophy, and the more they also tend to have not so much memory problems, but visual spatial problems. So the clinical picture is different, and the atrophy pattern tends to be different in younger patients. So there's a medial temporal typical pattern of Alzheimer's, usually in older patients who are ApoE4 positive, have memory problems. And then you have a posterior pattern, the posterior cortical atrophy. It's also a clinical entity with visual spatial disturbances, and often younger patients who are ApoE4 negative and have involvement of the parietal lobe. In addition, there are even more atypical patterns, including frontal or occipital predominance, who have either behavioral or visual symptoms, and these are really difficult to recognize during life because they may present like an FTD case or like a Lewy body dementia case, and I guess there are quite a few patients in that category who are misclassified and in fact have Alzheimer's disease. So, like for the visual rating of the hippocampus, we've developed a rating scale for posterior atrophy, first described by Esther Kudam, our PhD student, and Manja Lehmann from UCL has validated the scale also post-mortem. And on a scale from 0 to 3, one looks at the opening of the parieto-occipital fissure, the cingulate sulcus, the precuneus, and the interparietal sulcus that you can see on the surface on transverse images. Here's again a case of posterior cortical atrophy. This is a young patient, a 50-year-old male who came with cognitive problems. And if you look at the hippocampus on the right, is really completely, I'll go through it, completely normal. Oh, sorry. Whereas if you look at the parietal lobe here, the interparietal sulcus is widely open. So it's really very severe parietal atrophy, but the normal hippocampus. So in addition to the hippocampus, we always need to look at the parietal region as well. Again, as everything in medicine, this comes with a differential diagnosis. So this posterior type of atrophy we can see in AD, but we can also see it in Lewy body dementia, although maybe slightly more hippocampal, in cortical basal degeneration, and even in cerebrovascular disease. And sometimes some additional clinical clues may be of help, or additional testing may be of help. I already mentioned the dopamine imaging, and specific clinical features that may help. In terms of cortical basal degeneration, that's a very rare disease where you see asymmetry. So notice on the left you see the severe parietal atrophy, as we can see in PCA in Alzheimer's disease. But notice the asymmetry of the ventricles, and here we did perfusion. This is an ASL image showing also asymmetric perfusion. So in this disorder, which is a tauopathy, there's a very unilateral type of involvement of mostly the whole hemisphere. And the typical clinical finding is this so-called alien limb phenomenon, where people have difficulties recognizing their own arm, for example. I'm going to move on and talk about vascular pathology. So we talked about, remember, exclusion of a mass lesion, looking at swelling. Then we need to look at bright signals on the flare. So there's the CJD in the cortex, there's the primary white matter disease, and then there's the vascular pathology. The vascular pathology, there are many ways in which this can manifest. The most typical one is small vessel disease, causing diffuse signal changes on flare in the white matter, but you can also have multiple lacunes. There are only very few specific diseases. CADASIL is one of them, but 95% of the so-called small vessel vascular dementias have just sporadic etiologies. Then there's large vessel pathology, so strokes that may cause dementia, and sometimes the people have had a stroke clinically, sometimes these are silent infarcts. And then there are systemic causes of ischemia. We already discussed briefly the post-hypoxic demyelination, but you can also have mitochondrial diseases and vasculitis that may lead to dementia. Here's a overview of the types of pathology. So this is a large vessel pathology, a stroke in the posterior cerebral artery territory, leading to involvement of the hippocampus. As said, most commonly we see this diffuse high signal on flare in the white matter, but occasionally there are also small strategic lesions like these lacunes bilaterally in the thalamus. And notice that the brain is otherwise quite normal, so you have to look specifically at the thalamus to detect these lacunes that may be very important for cognition. And that is one of the reasons not to do only a flare but also a T2, because if you look at the flare here, it's very difficult to recognize the lesions in the medial thalamus. That's really obvious on the T2 weighted image. And we've looked at this more extensively, and about 50% of these thalamic lesions you miss on the flare, whereas even unilateral lacunes in the medial thalamus can have major impacts on cognitions. And if you have bilateral medial thalamus lesions, you can make a diagnosis of vascular dementia. So it's important to look specifically always at the thalamus. Again, simple visual rating scales are important. Frederik developed a simple scale that we use always in our routine reporting to describe these ischemic white matter lesions, going from punctate to early confluent and then completely confluent. So grade 1, 2, and 3. So punctate, early confluent, and confluent. And this is a simple scale, easily to apply, and has prognostic relevance. Here's a cartoon from the LADIS study, which was a pan-European study looking at what happened to people with these ischemic lesions who were living independently at home. And we had a stratified enrollment of subjects in Frederik's grade 1, 2, and 3. So this is enriched, of course, because in daily practice, most people will have a Frederik score of 1, but here we had a stratified enrollment. And you can see that after 3 years, that people with a Frederik score of 3 had only 30% chance to still be independent in their ADL functions or live at home. And in fact, many of these people had died in the meantime, not always of cerebrovascular disease, also of myocardial infarction, kidney failure, diabetes complications. So it's just a sign of general poor cardiovascular health. But it's a major risk factor independent of whether people have Alzheimer's pathology or not. So it's important to recognize it. So it's an independent risk factor, but it also probably accelerates Alzheimer's disease. It's not completely clear why, but probably if you have impaired blood flow to the brain, there's more amyloid being deposited, and there's an acceleration of a process that's already occurring. But in addition, if you have vascular damage in your brain, like with trauma, you have less brain reserve. So then at the lower threshold, you will become symptomatic if there's some neurodegenerative pathology developing. So it also just lowers your threshold, but it may in itself accelerate the Alzheimer pathology. He's a patient with pure vascular dementia, so extensive white matter lesions, multiple lacunes. So this fulfills official vascular dementia criteria. But if we look at the hippocampus, it's a very normal hippocampus. So this is probably really a pure vascular dementia without concomitant Alzheimer's disease. To be honest, this is a rare situation because most people with these extensive vascular pathologies, so for example, this case with extensive white matter lesions, lacunes, small cortical infarct, but then there's also very severe atrophy of the hippocampus. So this is a case of probably mixed dementia, so both vascular and neurodegenerative pathology. And therefore, we feel that we should partially leave these diagnostic labels, just look at what you see. If you see hippocampal atrophy, it's probably Alzheimer's pathology, and think about using cholinesterase inhibitors. And if you see in the same patient extensive white matter lesions, fine. Make sure you treat the cardiovascular risk factors and prevent further vascular damage. So don't try to give a patient one unique diagnosis only. If you see two types of pathologies, act upon them independently. Another pathology that we can see on MR, it has to do with the blood vessels, are so-called cerebral microbleeds that you can see on T2 star weighted images or SWI images. And we're talking about these little black dots that you can see. So on the left-hand side, you see them in very peripheral patterns, so cortical, subcortical distribution, also called a lobar distribution. On the right side, you see them in a central position, often in the thalamus, sometimes in the brainstem. And the central pattern is associated with cerebrovascular disease, so with hypertension, etc. Whereas the lobar pattern is related to amyloid angiopathy, to cerebral amyloid angiopathy. So that can occur either in the setting of Alzheimer's disease or in rare genetic diseases where patients have amyloid angiopathy and then also develop macroscopic bleeding. So two patterns, lobar and central. So if you see a lot of these lobar microbleeds, it's most likely amyloid angiopathy with or without Alzheimer's disease. But I must say that a lot of Alzheimer patients do not have microbleeds. So not finding them does not exclude Alzheimer's disease. But if you do find a lot of lobar microbleeds, it's consistent with. Another thing that you can see in Alzheimer's disease is so-called superficial siderosis, these dark lines that you can see. So there are multiple microbleeds in this case, but there's also superficial siderosis. So these dark lines around the cortical pile interface, or some people say subpial bleeding, very superficial. Something that you can find after a trauma or after subarachnoid hemorrhage, but if there's no history of that, then the alternative explanation is Alzheimer's disease. So lobar microbleeds and superficial siderosis are both manifestations of amyloid pathology in the blood vessels and consistent with Alzheimer's disease. Okay, so we've talked about atrophy patterns in Alzheimer's disease, And it's good to realize that when we see atrophy, we're probably relatively late into the disease. And in the next part of the talk, I will see what we can do to go a little bit earlier in time and find abnormalities that may occur before the dementia stage, for example, in the MCI stage, where we can perhaps see already a little bit of hippocampal atrophy, or even in people with subjective complaints or completely normal cognition. As I said, we talked a lot about atrophy patterns, and some of them are quite useful in the dementia stage to distinguish AD, FTD, PSP, and other disorders. But if you think about Alzheimer's disease, you really have to look at subtle signs like hippocampus or perhaps even entorhinal cortex to detect in this early phase of the disease. And Cliff Jack and others have developed models like this. This is Giovanni Frisoni's version of it, showing things that occur earlier. And we'll talk about amyloid deposition, which is probably one of the earliest events and almost plateaus by the time people present to memory clinics. And perhaps there are some marks that are slightly more in between. We were discussing how can you predict who will move on from MCI, for example, to dementia. And we talked about some medial temporal lobe structures already, entorhinal cortex, hippocampus. Here's a VBM study that we did to compare within a group of MCI patients whether gray matter density reduction could predict conversion to Alzheimer's disease. And the regions that are most predictive, as you would expect, are in the hippocampus, but in fact, also more lateral temporal regions already, consistent with the plots of the nonlinear registration that I showed you previously. So the more atrophy you develop, the more likely you are to convert, of course. But we would like to go even earlier, as I said, and therefore we now have at our disposal molecular imaging techniques. I will talk mostly about amyloid imaging that we can do using PET, and the first tracer that we were able to use was PIP, Pittsburgh compound B. The disadvantage was that it was labeled to carbon-11, which has a very short half-life time, so you need a cyclotron on site to produce and deliver it in time. But nowadays we have various fluorinated tracers, and they have a much longer half-life time. And the three that are registered are flutemetamol, florbetaben, and florbetapir. And in the Amyloid PET projects, we use flutemetamol and florbetaben. These two, and they both have are fluorinated. Other tracers that we have are dopamine receptor images, which are usually done with SPECT, although you've seen that there are also PET tracers for dopamine, but usually done with SPECT. And DAT-scan is the most widely used one for SPECT. And then there are tracers coming up for tau pathology. The most widely used in research studies is the AV1451, which is a research tracer. Others are in development, including more commercial tracers, but that's still a long way to go. And what is missing is for other protein pathologies, for example, alpha-synuclein, that you can find in Lewy body dementia, for example, or some other traces that are relevant in the FTD spectrum. Talking about amyloid, so this, as I said, PIP was the first one, but you can obtain similar images with other fluorinated tracers we've seen it. And the big difference between a control and an AD is not the white matter, because the white matter has some non-specific binding. The difference is in the cortex. So in a normal control, you will see no uptake in the cortex. So you see a nice separation between the cortex and the white matter. Whereas in a patient with AD, but we'll see also in other amyloid positive patients, you see uptake in the cortex, and you can not see this gray and white matter differentiation anymore. And since the gray matter has these sort of finger-like extensions, it's important to make sure that you can still see these finger-like projections without cortex. Whereas in AD, you see the whole brain takes up, and you cannot see these finger-like projections of the white matter anymore. It doesn't really matter where this occurs, because the amyloid pathology tends to be rather diffuse throughout the cortex. So don't pay attention whether it's frontal or parietal. Like for the atrophy patterns, you have to look at the regional specificity. There's much less regional specificity in the amyloid PET. It's more a diffuse uptake. So here are the fluorinated tracers. On the right, you see them all in black and white, although flutometamol is usually used in color, but to make it comparable, they're all reproduced in black and white here. And you can see that they have fairly similar patterns of binding in the white matter in healthy controls, and then diffuse uptake in the cortex with loss of gray-white matter differentiation in AD. And as I said, it's especially useful to pick up AD in contrast to healthy controls, but also to FTD. Here's an example again from the Windblad paper that I mentioned earlier on in the Lancet Neurology, showing again a negative scan in a healthy control with preserved gray-white matter differentiation, and then two positive cases, both done with PIP, but you could have done it with another tracer. Both MCI. I'm sorry, this is the Alzheimer patient positive, and these are two MCI cases. So this is a negative and a positive MCI case, and the positive one converted to dementia within the follow-up of 2 years, and the negative one remained MCI. So had no evidence of Alzheimer's, nor on imaging, nor clinically. As always in medicine, I said there are exceptions, and there are also other diseases where you can find amyloid uptake. So a certain percentage of cases with DLB, for example, can have a positive amyloid scan, which is perhaps not a surprise because also the pathologist will describe a variable degree of Alzheimer pathology in cases with Lewy body dementia. And that probably explains why also in some centers there's a higher number of patients being diagnosed as Lewy body dementia than other centers. This one I already showed. Yeah, so as I said, for Lewy body, we need to look at the dopamine imaging. This is from the recently revised Lewy body DLB criteria that was published only last year. Of course, in Lewy body dementia, you tend to have a normal hippocampus in contrast with AD, but then you have very reduced uptake of the dopamine tracer, which should be in the caudate and the putamen, so it should be sort of comma-like structure. And you can see that initially this tail is eroded, and then in the end there's only a little bit of uptake left in the caudate, with only these two dots of low intensity remaining. So a very simple test to confirm DLB. I mentioned already that atherosclerosis is something that may impact AD as well. Here's a nice study, a postmortem study, where they looked at the carotid arteries and classified them as almost normal or severely atheromatous with narrowed lumen. So this is all plaques forming in the wall of the vessel with a very severely reduced lumen. Obviously, this will impair the blood flow. And it turns out, if you look at AD, that there is a higher proportion of patients with narrowing of the carotids. And probably, as I said, the narrowing of the carotids will impair the blood flow and hence also accumulate the formation of amyloid plaques and downstream events leading to neurodegeneration. And in this nice case report, they showed they did an amyloid scan in a patient with a unilateral carotid stenosis. So on the top, and so the stenosis was on this side, and you can see on this part of the brain there's also more uptake of the amyloid than on the left side, and which should be symmetrical, of course, if you don't have a stenosis. The other thing is, how good is amyloid PET versus CSF analysis of amyloid? And here's data that a slide that I got from Bill Jagos from the EPAD study, where they compared the cortical uptake value, which is the standard uptake value ratio. So this is a standard way to report the PET signal, amyloid PET signal in the cortex versus a reference region, typically the cerebellar gray matter, compared to the CSF amyloid. And so here's the confusion matrix. So if you have an increased amyloid uptake in the brain, you often find a decreased CSF amyloid value. So as I said, amyloid is a normal protein. So you have some amyloid in your brain and in your CSF, which is a normal finding. The abnormal finding is if the amyloid goes down, probably because it all gets deposited into your brain. So basically taken out of the CSF, going into the brain. So overall, there's a good concordance between a normal CSF and PET finding and an abnormal CSF and PET finding. And that's all fine. You know, the ADs are mostly in the abnormal quadrant, which is all fine. The MCI patients are some here and normal, some abnormal. That's also fine because we know that only half of them will develop dementia AD and the others not. What is really scary is the controls. The controls are also randomly negative and positive. And that is the issue with amyloid PET and with amyloid pathology also in postmortem studies, that this starts probably many years before people reach the memory clinic. So if you plot, and this is a slide from Chris Rao from the ABLE study, if you look at the prevalence of AD, it increases exponentially with age, clinically. This is clinical AD. If you look at autopsy studies about findings indicative of Alzheimer's disease, plaques in healthy elderly populations who come to autopsy, you can see that there's also an expansion and an increase, but it occurs much earlier than the clinical disease. And if you look at the amyloid positive PET rate in healthy controls, you can see that it also increases with age, very much like the pathology studies, and that there's about a 15, if not 20 years lag time between when you're expected to develop Alzheimer's pathology in your brain and when you present with Alzheimer's dementia in a clinic. And that's the problem with amyloid PET, that it's positive in a very early phase, even before people have any cognitive complaints. So if you randomly pick 100 65-year-olds from the street, some 25%, or no, probably some 20% will have a positive scan. If you take 70-year-olds from the street, then almost half of them will have a positive scan already, without having any signs of cognitive decline or other evidence of a neurodegenerative disease. So it's a very sensitive, too sensitive measure for a clinical setting. But of course, it's a very good marker if you want to identify people very early on in their disease course, where you could prevent neurodegeneration. And that's the whole concept of EPAD and AMyPAD, of course, that you want to intercept people at a stage where there's already evidence. So the first signs of Alzheimer's pathology development, also referred to as preclinical Alzheimer's disease, so no clinical signs. And this gives you a window of opportunity of about 50 to 20 years to try to prevent subsequent events like tau pathology, neurodegeneration, and atrophy to occur. So coming back to this cartoon with amyloid, we're on the very early side of it, and this is very a fortunate situation for studies like EPAD and AMyPAD, and also provides a window for secondary prevention. But in a clinical setting, it's too early, because the fact that somebody, if you, let's say, patient comes in with memory complaints, you find a positive scan. Well, a positive scan could also be found in a healthy elderly. So the predictive value for Alzheimer's disease is not very high in the short run, whereas the atrophy is a bit late. So what we're constantly looking for are things that slightly more in between, closer to what is called the disease onset. One possible candidate for this is tau PET. So here's another tau tracer that doesn't bind to amyloid but to tau. And here's one of the first studies. I'll show some other examples in a second. This tracer is not used very often anymore, but it's an AD patient with a lot of amyloid in their brain. Interestingly, often doesn't bind to the hippocampus very much. And in the tau tracer, you see uptake in the hippocampus and the temporal regions, which you don't see in the healthy control. And Rick Ossekoppelen from my center in Amsterdam, pooling data from San Francisco and some other centers, looked at tau PET in Alzheimer's, and it turns out, as we already discussed, that there are variants of Alzheimer's disease or subtypes of Alzheimer's disease. And I discussed previously with you the posterior cortical atrophy pattern, and as you would expect, people with PCA, these younger onset AD patients, you remember, have mostly pathology in the precuneus and in the more lateral parietal areas, also the occipital areas, whereas the typical amnestic ones, the one with hippocampal atrophy, have it more in the hippocampus and the rest of the temporal lobe. But then there are also Alzheimer patients who present mostly with language problems, who have a more widespread pattern with a lot of involvement of the temporal lobe, but then the lateral side of the temporal lobe. And then, more confusingly, there are also people with more behavioral pattern, with a more diffuse pattern, or with a cortical basal syndrome. So I don't want to get lost in the lower row, but the top row is roughly consistent with what we've seen already on MR. And this nicely shows you the distribution of the tau pathology in the various subgroups. So also closer to disease onset are functional imaging techniques. So remember, on one side we had structural imaging, which is late, MR, CT, molecular imaging, some of it is very early, some of it closer to disease onset, and then we have the functional imaging, which is roughly in between. And the most well-studied are this SPECT tracer called HMPAO, which is not used very much anymore. Much preferred is FDG PET, which shows glucose metabolism. And upcoming are arterial spin labeling to measure blood flow, which is related but not the same as glucose metabolism. And then we have resting state fMRI, which measures brain activity in an indirect measure. So these are all interrelated measures, but the underlying physiological principle is different. FDG here is shown with the patterns that you can see in dementia. So in AD, we see reduced uptake in the precuneus, also where we see a lot of atrophy and the tau accumulation, but also more on the lateral side of the brain in the temporal parietal distribution. Lewy body, as on MR, has a very diffuse pattern, non-specific. FTD, as you would expect, has severe hypometabolism, either in the frontal or in the temporal lobe areas, as you can see here. Again, these two patterns we can also see on MR. Here's a study showing from Jill Rabinovich from San Francisco, showing again the combination of two of those tracers, which is a luxury that we don't often have, but I think it's illustrative. These are cases that came to autopsy. So the first one is a patient who was amyloid PET positive and had an abnormal FDG with low metabolism in the parietal temporal areas. All of which is consistent with AD, which was confirmed at pathology. Then there was one who was clinically an FTLD patient with a bit of motor neuron disease admixed, and there's, I didn't mention that yet, but there is an overlap between FTD and ALS. This patient was amyloid negative, but then had an FDG scan which was positive, but now not in the temporal parietal region positive, but positive in the frontal region. All of this consistent with FTD, which then confirmed at pathology. But the most confusing one is the third patient, who was clinically an AD patient with amyloid. But then the FDG showed mostly frontal abnormalities. So you could think of FTLD, but then at autopsy was in the end an AD. So this was an AD with quite a bit of frontal lobe involvement. And this goes back to the slide that I showed here, that you have some patients with more behavioral presentation who have a more widespread distribution of the tau pathology throughout the brain. To be honest, this is really a confusing category because sometimes it can be really difficult to differentiate from FTD. Looking at disease progression, here's a cartoon showing progression of hypometabolism. So this is a early patient with AD with a relatively normal MMSE score, with a normal metabolism, tracer uptake showing normal metabolism in the cortex. And then as disease progresses, so these are different patients, you can see that there is progressive loss of tracer uptake, so progressive lower metabolism. And on the statistical maps, you can see that the whole brain becomes diffusely abnormal. We can also use fMRI. Task-based fMRI has been used in AD, and you can see reduced uptake with various tasks. This was some work that we did a long time ago with visual encoding, so a memory paradigm, and you can see that people had difficulties to activate their brains in the relevant regions. And if you give them some cholinergic enhancement, this was with another task with face encoding, you can see that you overall increase the brain activation upon a task, consistent with the fact that these drugs have some effect in the short term in patients with Alzheimer's disease. But fMRI is difficult to do in Alzheimer's patients who may not understand the instructions very well. So rather than looking at a task and see how brain function changes with the task, you can also just do an fMRI and don't apply a task. So, and then you see what seems like noise, but it's in fact not noise. It's small task or small activity that occurs in the brain over time. And in fact, the activation is only the tip of the iceberg, are these peaks, whereas in fact the whole, the major activity is occurring in the background. And with resting state fMRI, you can look at these resting state signals and show networks, and you identify them by looking at synchronous fluctuations of signal between two brain areas. And then you can find all these networks, and you can do this in individual subjects, and each and every one of you who would go into the scanner for 5 to 10 minutes, we will find the same networks. Some of them are related to working memory, some to attention, some to executive function. Some are simple sensory motor networks or primary visual networks, auditory networks, and they always show up. One of the networks that probably has most attention is the default mode network. And the default mode network is something that is active when you're not performing a task. In fact, it was discovered while doing task fMRI that when certain areas relate to the task become active, this area actually becomes deactivated. And this is one of the most active networks in rest. Probably a sort of consciousness or constant monitoring process related to being awake and processing in a default mode. And so here again is showing, if you look at the in a seat in this posterior cingulate area, you can see that if you look at the time course here, it goes up and down. And if you look at another area, the orange one, you can see that it moves up and down in the same way. So it looks like noise, but it's not noise. These are variations in brain activity status, and they move synchronously in certain areas of the brain. That's how you define the networks. Whereas if you look, for example, here in a more sensory motor area, has a completely different time course. Hence, you find it in a different component when you do the ICA. So this default mode network, as I said, encompasses the posterior cingulate and the precuneus, and this is exactly where with FDG you find reduced uptake. So the posterior cingulate precuneus are really the sweet spot of Alzheimer's disease, where you see atrophy, where you see abnormalities with FDG, abnormalities with resting state. Here's a study that we did to look in patients with AD to show reduced connectivity in the default mode network. And what happens then, in fact, so you get lower connections to various posterior brain regions. And interestingly, some other areas, more frontal areas, get increased connections. And there's a bit of debate what this means. Some people say this is compensatory activity to account for the loss of connections. Other people think this is actually deleterious. So this remains to establish whether this is in fact compensation or more maladaptation of the brain networks. And the final technique I want to mention is arterial spin labeling, which is a non-invasive labeling of blood, which you can then read out in the brain using MR. So it's a technique that does not require contrast administration, and you can then create these beautiful perfusion maps, here shown only in the gray matter. And as you would expect, the perfusion goes down considerably in AD and is sort of intermediate in MCI. So relatively good effect size, but the problem is that there's quite a bit of variability in the brain under normal circumstances, which is poorly understood. On a group level, though, you do see that there are very significant differences between AD and MCI versus controls. Again, involving the areas that we also see in the default mode, so the precuneus, but also more lateral parietal areas that we see on FDG. So overall, it's relatively concordant with FDG, but FDG has a better signal to noise than ASL. Disadvantage, of course, is that you have to inject a tracer and that it's and radioactivity is involved. And here's an ASL study where we looked at the effect of atrophy and small vessel disease. So this is a normal control. If you have white matter lesions only, so a bit of ischemic cerebrovascular disease, you get a slight reduction in overall perfusion. But if you have atrophy, you get a stronger reduction. So atrophy has a stronger effect on the brain perfusion than these ischemic lesions. But the worst perfusion is seen in people who have a combination of atrophy and cerebrovascular pathology. So again, this comes back to my earlier point that we have two different types of pathologies that can both affect the brain, ischemic and neurodegenerative pathology, and they have an independent effect on perfusion, but also on cognition. So the final few slides, I want to talk briefly about drug development and why that fails and how imaging can contribute. One of the biggest questions is, of course, what causes AD? And although we are all quite dogmatic in thinking that amyloid is the first stage, we're not completely sure. Those are people who develop tau without amyloid. But I think if you look at the genetic mutations in the presenilin, etc., it's all in the amyloid pathway. So there is good evidence to think that it is amyloid driven. Then it could be the drugs. Various ways to work on amyloid. Either you can do vaccination, or you can try to reduce the metabolism of amyloid, so removal or upbuild you can attack, but then are you going to attack the monomers or the oligomers or the fibrillary amyloid? And the various drugs all have different profiles, and it's quite a strong debate what is most important. New targets are being developed, for example for tau, also very interesting. If we focus on amyloid, if you look at the bapineuzumab studies, which were negative, that were selected only on clinical grounds, later on a PET study was done in a subgroup, and it turned out that 35% of the subjects in those trials with clinical Alzheimer's disease had a negative PET scan. So much about clinical certainty. So if you, I think, you know, whatever you think of these 35%, perhaps they have another form of Alzheimer's disease, but obviously not very good candidates for an amyloid therapy. So that is clearly where imaging can play a role in making sure that people who go into these trials do have amyloid pathology on board. And obviously the final thing you can debate are the outcome measures, but I'm not going to go into that for now. So amyloid, most people still put in the central part, also because of the familial cases, all have an amyloid mutation. But obviously amyloid has to then do something to the synapses or induce tau aggregation and then induce neuronal death, which all, you know, could be disconnected pathways, because there are various other risk factors, including the cardiovascular ones, that may stimulate the Alzheimer, the amyloid pathology, but they also may independently act on tau aggregation or even cause neuronal death. And that is why these therapies may, in the long run, not be the only solution to stop this pathway. But nevertheless, the trials that are ongoing at the moment are mostly trying to do something either on the reduction of amyloid or try to remove the amyloid with antibodies. And interestingly, if you look on amyloid PET studies, in the bapineuzumab studies, so this was one of the earlier studies, it was seen that if in patients with amyloid in their brain, after treatment, there's actually a reduction of the amyloid in the brain, whereas in placebo patients, you can see that there's an increase in amyloid over time. So these drugs do what they're supposed to do. They do bind to amyloid and they do remove the amyloid from the brain. And in fact, if you remove it too quickly, you can develop an inflammatory reaction. So on the left side, you see a picture, a flare image before therapy, and then during therapy, this patient developed an area of edema, relatively subtle in this case, sometimes can be much more extensive. Most of these are asymptomatic, and then when you stop the drug, it decreases and in fact also disappears after a while. And we call this the so-called ARIA-related imaging abnormalities, or ARIA. Interestingly, in this same location, this patient then developed microbleeds, which he hadn't before. And as we've seen previously, these microbleeds we also find in sporadic, just incidentally in Alzheimer's disease, and related to amyloid in the blood vessels, which then cause damage in the vessel wall and make it more fragile. So this drug may induce edema or inflammation. There's debated what it exactly is, but it may also induce microbleeds. And interestingly, in this patient, we had a PET scan before and after, so this was the baseline scan. And if you looked at the change in the PET, so the biggest change occurred in the area where the patient developed the ARIA and also where it developed microbleeds. So probably if you remove the amyloid too quickly, you get a reduction, you remove it from the tissue, move it to the vessel walls, and then induce the edema and also the microbleeds. Here's another drug that is currently still ongoing, aducanumab, and this is from the phase 1 study. This drug has a very strong effect on the amyloid in the brain. And I guess that a lot of you have seen these data. So this is from the phase 2 study, where they had a baseline scans of 4 different subjects, and there was placebo versus 3 doses. And you can see there's a very dramatic effect on with higher doses on the amyloid in the brain over less than a year's time. In a dose-dependent effect, you see a removal of the amyloid. And the good thing is, in this study, there was also an effect on the cognition occurring. Oh, this is almost too good to be true. We really need to wait the phase 3 studies, which are ongoing. So here's the effect on the MSE. This is on the CDR sum of boxes. But what I found most interesting in this paper is this small panel here at the bottom. And I'll zoom in on that for you. So this is looking at the change in the CDR sum of boxes, which is a general dementia score. And on the right side, you see on the change in the mini-mental state examination score, another general dementia score. And the blue and the orange ones are people where there was a reduction in the amyloid on the PET, or where there was less than 1 standard deviation reduction of the amyloid on the PET. So the blue ones is where there was more removal of amyloid. And you can see that the changes in the CDR sum of boxes occurred mostly in the people where there was removal of amyloid on the PET. And similarly for the MSE, if you had a good removal of amyloid, the MSE stayed relatively stable. If there was a mediocre removal of amyloid, these people deteriorated. Again, this is a small phase 2 study, almost too good to be true. That's why I got into Nature, of course, but I genuinely hope that the phase 3 studies will be equally positive. And as I said, it also shows that it's important to select patients with amyloid, either on amyloid PET or through CSF analysis, and make sure that if you try these therapies, you have people with amyloid on board, but also that you monitor whether the amyloid is removed, for example, with PET again. But on the other hand, as these side effects, these ARIA may occur, and that may occur up to 20 if not 30% in some of these therapies, you need to do regular MRI to make sure that people don't develop ARIA, and that you can adjust the dose or have a drug holiday before you then build it up again. So to summarize a few take-home measures. So I talked quite a bit about structural imaging, looking at atrophy patterns. Remember the hippocampus. Remember the mesencephalon that we can look at. Remember the asymmetric temporal lobe atrophy. But remember also posterior cortical atrophy pattern in younger AD patients. And we talked about molecular imaging, amyloid tracers, which are most studied, very sensitive, excellent for research setting and secondary prevention, but in a clinical situation have a low positive predictive value because it happens in normal aging. More useful, in fact, to exclude Alzheimer's, for example, if you're also considering an FTD. Tau tracers are developing, interesting topic as well. We talked a bit about functional imaging to go between these very early amyloid and the late atrophy patterns in Alzheimer's. FTG is best validated, but of course is invasive because of the radiation. And if you're doing a PET scan, and more, I would be inclined to use that for molecular imaging to show the protein abnormalities, either amyloid or tau, and hopefully ASL or resting fMRI will be further validated to then replace FTG for that particular application. And finally, we talked about therapy development and monitoring, how we can use amyloid PET to select people that are candidates for secondary prevention. But on the other hand, you could monitor the effect of the drug, and you can use MRI to look at the side effects on one hand, but also monitor the outcome in terms of can we preserve the brain and prevent atrophy occurring. And I want to thank my longtime contributors, Philip Sheltons, who's in the Alzheimer's Center in Amsterdam, and Nick Fox, who heads the Dementia Research Center here in England. And again, alert you to the book that we did, where a lot of this information is summarized, and also mention again the website, radiologyassistant.nl, where you can find a lot of the information that I just tried to share with you in this webinar. And in closing, I want to mention, of course, also the two projects that are important here, EPAD and the EPAD Academy, and alongside with it, AMyPET, the project that complements EPAD to do the amyloid PET imaging. Thank you everybody for attending, and I hope it was clear. And if you have further questions while you contemplate about the lecture, don't hesitate to send a question by email, and I'll try to answer it. Okay? Bye-bye.